Management algorithm of the Hallux Valgus involves, first of all, the complete assessment of the patient. That is, you have to assess the patient based on his symptoms, signs, examination, and then the radiographic assessment as well. We start with the symptoms of history, that is, include mainly the pain, location, and duration, because we have to assess the first metatarsophalangeal joint as well as the hypermobility, the tarsometatarsal joint as well. What is important is how much is the current activity level as well, because if the patient is young and more mobile, this means there will be increased chances of increased arthritic development of the first metatarsophalangeal joint, and probably some form of osteotomy would be difficult to perform later on. Then we have to, if a patient has, we have to assess the wearing habits. Why it is important? Because usually females have a tendency to wear shoes with high heels and narrow toe box, because this is one of the contributing factors to development of Hallux valgus, which happens to be a progressive disorder. So we have to stop them from wearing this shoe, and we have to ask them to wear shoes with a wider toe box and avoid very high heels shoe as well. Then family history, because if there is patient has a genetic predisposition, all these orthotics, shoe wears and insoles will not really work, because the patient is genetically more predisposed to having a disease. There will be, this means despite doing all the necessary preventive workup, the patient will have this problem later on. So you need not only to counsel the patient regarding this problem, but we'll also need to assess this patient, that probably this patient will have a more severe form of disease than that person who has more of environmental issues related, or actually has a mechanical problems related to the foot, like wearing high heels or not. And then we have to assess the detail how much patient has any taken any management, like for example, has patient taken any gone into orthosis or any orthotic device patient is used or not. Because if the patient has already used, for example, insoles and toe splitters and it hasn't worked, this means again using them will not work. So we'll have to straight away go for some form of an operative treatment. Then comes the physical sign. We have to assess the foot as a whole, that is the forefoot, midfoot, as well as the hind foot. We have to assess the range of the first metatarsophalangeal joint. Why it is important? Because if this range is, there is decreased range of motion, or there is crepitus, or there is pain during the motion, this means there is probably arthritis. And instead of going for osteotomy, we may have to go for some form of orthodesis as well. Then we have to assess the mobility of the first tarsometatarsal joint as well, because it's a problem of first ray, which involves the problem with the tarsometatarsal joint, first metatarsal head, first metatarsophalangeal joint, and all the way up to the phalanges. Therefore, the whole ray is involved. We need to assess the whole ray as a whole. Then the longitudinal arch height. Usually these patients we have seen that with the development of Hallux valgus, there's usually depression of the first or middle arch of the foot. Then we have to assess how much the metatarsal has gone into a pronation, because if it has gone into plantar flexion and pronation, this means there will be a lot of under coverage of the first metatarsal head, and under coverage which means that we may have to go for some form of a Bony procedure on the metatarsal head as well. Then tension of the gastrosoleus muscle. Why this is important, and this is the reason actually which is disturbing the whole gait kinematics, because there is increased hyperactivity of gastrosoleus muscle. That is why these patients sometimes also complain of fatigue and pain and problems when they walk over the period of long period of times. Then once you've taken the detailed history, examination, and radiographic measurements, and radiographic measurement includes certain angles which has been briefly explained. That is the Hallux valgus angle, which should be less than 15, intermetatarsal angle, which should be less than 9, Hallux valgus interphalangeus angle, distal metatarsal articular angle, and we have to look at the sesamoid position as well. We know by our pathoanatomy that the sesamoids are actually lateralized, and the whole metatarsal and metatarsal head is actually medialized. This leads, if they're too much lateralized, then probably we'll have to go for certain tenotomies of the flexor hallucis brevis muscle as well, because the sesamoids are actually present inside the flexor brevis muscle. Then we have to calculate Hallux interphalangeal muscle angle, which is important. Whether if it is there's too much deviation, we may have to go for certain osteotomy called as echinosteotomy. Degenerative arthritis, if it's arthritis, the only option probably is to either go for orthodesis or go for something replacement surgery, but usually the replacement surgery is not being much successful. Therefore orthodesis is the go-to option in the case of degenerative arthritis. And important is relative length of metatarsal. What is usually seen with these is that there is actually, this results in actually increase in the length of the second metatarsal, and despite the correction of all angles, the load is still going through the second metatarsal in the body, and therefore the patient will come again repeatedly with either the stress fracture of the second metatarsal or the problem related to called as transverse metatarsalgia, or the pain is mainly to shifting towards the other or lesser toes. Once we have done this, we have taken this, sometimes you require stress view, but usually the AP lateral oblique view, which are more weight bearing, are more than enough. But sometimes to assess exactly the distal metatarsal article angle, you may require a stress view of the first metatarsal joint as well. Once we have taken the detailed history examination and radiographically assessed it, we can classify into mild, moderate, or severe category of Hallux valgus. Once we have categorized into which form, then we have to go for what is the situation of the, which is more importantly, corrective operations is required, or you require certain orthosis, for example, conservative treatment such as toe splitters, insole, or use of any the cushion pads or not. But then what matters is what is the situation of first metatarsophalangeal joint. As you know, there are two joints which are involved. One is the first metatarsophalangeal joint, and then is the first tarsometatarsal joint. These two joints are very important. If there is first metatarsophalangeal joint subluxation, that is, and sigmoid subluxation, you go for soft tissue procedure in mild to moderate sort of Hallux valgus. If, as I told you, intermetatarsal angle is increased, or there is increased distal metatarsal articular angle, and then you may have to go for certain osseous procedure along with the soft tissue procedure, that is the modified McBride. And sometimes it's such a severe disease that there are multiple problems at the Hallux. There is deranged Hallux valgus interphalangeal angle, there is deranged intermetatarsal angle, there may be deranged Hallux valgus angle. So you have to do multiple osteotomies. Sometimes you have to go with the distal as well as the diaphyseal osteotomy, or called as double osteotomy, along with the echinosteotomy at the between the first proximal and distal failings as well. So then you have to assess what is the situation of the first metatarsophalangeal joint as well as what is the situation of tarsometatarsal joint. If we are going for combined procedure, we can go for wheel or echinosteotomy, and echinosteotomy is done when there is actually Hallux valgus interphalangeal angle is more than 10 degrees. Means there is increased deviation at proximal distal failings, which would lead to disturbance at the Hallux valgus interphalangeal angle. But if it is soft tissue procedure with mild subluxation or mild to moderate subluxation of first metatarsophalangeal joint as well as sigmoid subluxation, we may have to go for certain soft tissue procedure or basic manipulation in form of orthosis as well. But sometimes we may have to go for osteotomies and orthodesis as well. And osteotomy can be isolated distal osteotomy, that is chevron, or it could be multiple diaphyseal osteotomy such as scarf, or it could be a double osteotomy such as involving the distal as well as the diaphysis of the metatarsal, or it could be even the basal realignment osteotomy as well. Now all these osteotomies can be used depending upon surgeon's preference as well as surgeon's experience. Most of them are good at chevron. They can go for uniplanar chevron or they can go for biplanar chevron as well. Why biplanar chevron is required? Because you know that most metatarsal is going in plantar flexion as well as pronation. Therefore, to correct the plantar flexion, we have to first go for osteotomy in single plane, and to correct the pronation, you will require another osteotomy in another plane to actually correct the pronation of the first metatarsal. So most of the time, you require a biplanar osteotomy, or it may require a basal osteotomy if it is moderate to severe form of a disease. Usually scarf or Ludloff osteotomy is also done for moderate to severe form of disease. But if it is mild to moderate disease, distant chevron osteotomy is more than enough. If it happens to be arthritis of the first tarsophalangeal joint, then we may have to go straight away for the orthodesis of the first metatarsophalangeal joint. And why we need to go for that? Because if we go for osteotomy, despite correction of the angles, the arthritic pain will not go away and patient will still have the problems of first metatarsophalangeal joint. Therefore, to make the patient pain-free, we have to go for orthodesis of the joint in the corrected position. And if there is too much hypermobility at the first tarsometatarsal joint, usually you need to go for some form of either the basal realignment osteotomy or orthodesis of the first tarsometatarsal joint, called as the Lapidus procedure. One thing which from this algorithm is very much clear, that there is no acute cutoff when to call a disease mild, when to call it moderate, and when to call it severe. It's mainly based on the clinical experience, examination, history, and your radiographic evaluation as well. Plus, you need to assess the gait mechanisms of the patient as well, and how much problem in the gait is actually having for the patient. Therefore, based on your clinical judgment as well as your radiographic assessment, you can either go for any of the osteotomy or soft tissue procedure alone. But broadly, when we deal with the mild to moderate sort of a Hallux valgus, we usually either go with soft tissue procedure along with the distal chevron osteotomy. But if we are dealing with moderate to severe, we may have to go for osteotomies such as scarf or double osteotomy at the metatarsal. We may have to go for Lapidus procedure at the first tarsometatarsal joint, and we may have to even go for Achen osteotomy and between the proximal and distal phalanx as well. All this depends upon the clinical expertise and the assessment of the orthopedic surgeon.